University of Florida. She'll be speaking today on intraocular lens management in PK surgery.
Thank you, Tony, for the invitation to speak here today. And again, when I started doing PKs, it was, we'd take the cataract out, put a lens in, and it didn't matter what it was, people were happy because we were doing it for patients who really couldn't see. And now the expectations with PKs have changed just like they have for DMEX and DSEC, and everybody wants to be 20/20 uncorrected. So this becomes even, has become a problem even with patients that we didn't used to have problems. So what's the problem? When we have PK surgery, there is issues with post-PK cataract surgery, figuring out the IOL calculations. And when you do a combined surgery, which again, in my practice, we do several of, just because our patients come from so far away, they can't really stage these. Ideally, you want to do the PK first and then do the cataract after you've removed all the sutures. One of the problems, again, with PKs, just like other corneal transplant surgeries, is trying to figure out this whole relationship between anterior and posterior curvatures. They all change even with PKs because you have the sutures, there's higher order aberrations, and sometimes some of the assumptions you make when you measure corneas using placido-based measurements aren't very accurate. And with PKs, sometimes even using Steinflug is not as accurate because you've got multifocal corneas. And then what do you do with patients who've got high levels of astigmatism following a PK? And then we'll talk about combined PKs. So when you have an irregular astigmatism patient, these are patients that I often actually am pretty relieved about because I tell them, you really can't not get away without wearing contact lenses. Once they're going to wear a contact lens after the cataract surgery, the risk, I relax a lot, right? Because I can't really go too far wrong because whatever I do, my optometrist can fix with a contact lens afterwards and they'll be happy. So I don't tell them to stop their contact lens use before I do my measurements because they're dependent on their contact lenses and they're very unhappy about stopping those even for a short while. So I will take them out, but then I tell them, it might be off a little bit, but that much is probably not an issue because you're going to go back to contacts afterwards. We talked about this yesterday. When I do a cataract surgery, every patient that walks into my office at least says, oh yes, I want 20/20 at distance. And you have to temper these expectations, tell them, you're never going to see 20/20 without your contacts. I will get you 20/20 with your contacts if the cornea is clear and everything else looks good. But the only thing you need to see without your contact is your contact. So you need to be minus 250 so that you can see that contact to put it in your eye. If you drop that in your drain and you are corrected for distance, you wouldn't be able to find that contact. So you want to make sure that they understand that you're going to correct them for near. That also gives you a little bit of leeway because if they end up a little bit closer, a little bit further away, they still have useful-ish vision at some distance. If they're irregular, you can still attempt corneal things that you can try to do to decrease the amount of astigmatism they have. So if you can see that they're irregular but mostly regular and mostly have astigmatism in one direction, you can do relaxing incisions. You can put compression sutures in the opposite direction because even with that, when you put a contact lens, you can get rid of all the errors. But you do not absolutely want to put a toric lens in these patients. And they will need contact lens refitting after the surgery because you are changing the intraocular lens power that they have. The regular astigmatism patients become a lot more complex with PK surgery because these patients do want to be able to get rid of their contact lenses. If they plan to wear the contact lenses, then again, you can relax, you do the same thing as you do with an irregular cornea. But if they don't want to wear a contact lens, now the discussion becomes a lot more significant and you have to have them remove those contact lenses for a while. And I say about a month, but oftentimes if you see that they're warped, you do a topography and their warpage hasn't completely resolved, you might need to wait 2 months or 3 months to let their corneas completely relax. And a lot of these patients who've been wearing things like rose K lenses or other RGP lenses, their corneas can take a long time to get unwarped. And so you want them to be out of those contacts before you do the measurements. Now again, corneal relaxing incisions, compression sutures are usually not an issue because you can do those. if you put a toric lens, you better be very, very sure that they are not going to go back to a contact lens after surgery. Because you put a toric lens in and they put a contact lens on top, now you've gotten the opposite of their initial astigmatism, and they will be very unhappy. And then, do you correct them for distance versus a little bit myopia? I still try to adjust them for a little bit of myopia. I tell them the advantages of being able to, and a lot of people who've had PKs for keratoconus, for example, several years ago, they know what it's like to have myopia and not have that. And they are often not very unhappy about having near vision. And that, again, gives you a little bit of wiggle room, because they can always move things if you're not right on the mark. We saw some of the talks about how do you do measurements in irregular corneas, and a lot of these apply to the PK, so I won't reiterate those. But you do want to maybe give yourself a little bit of wiggle room when you're doing these surgeries, because they don't always end up right. When you're using a toric lens, again, make sure they don't want to wear contact lenses. Make sure the astigmatism is very, very regular. Now, again, a lot of these patients are used to not having great vision if they don't wear contact lenses, and they're just happy not to have to put their glasses on first thing in the morning, and they're willing to put up with a little bit of irregularity or not perfect vision. And sometimes that gives them a multifocal cornea, so they actually like that, because they can see different distances, like our keratoconic patients, from different parts of their cornea. So I'm a little bit more flexible with the amount of astigmatism that's regular versus irregular. And then make sure your astigmatism aligns with different instruments. If you're getting them different in different instruments, then do not put a toric lens in. And again, make sure all their sutures are out before you do this. I've had patients 20 years from PK surgery that my partner did, and they broke a suture and flipped 10 diopters in the opposite direction. So you want to make sure that if you're going to put a toric lens, you better be sure they're not going to change. And we used to tell people you can't get a toric lens if you are young, because you might need another transplant. Now we don't typically do PKs for PK failures. We do endothelial keratoplasty, which is more forgiving. So here's an example. I think I showed that to some people yesterday, so ignore me if you've already heard this, but this was a patient that I used intraocular aberrometry, PK for a fungal ulcer, did really well except 10 diopters of astigmatism, no sutures in the direction of astigmatism, all their sutures were out. I couldn't get any measurements, but it was pretty regular. So we did intraocular, I put a toric lens in, and the astigmatism went from 10 to about 6. We then put in some relaxing incisions, and the astigmatism went down to 4 diopters. I then put compression sutures, and I flipped them from against the rule to 4 diopters with the rule. So I took a couple of sutures out, and they were then down to 1.5 to 2 diopters of astigmatism with the rule, which I thought was a pretty good outcome. She was thrilled. The other eye had RK2 and was hyperopic. She was matched up. She was 20/20 with small prescription for glasses, and very happy with this. Even though it wasn't perfectly regular, she still got a pretty good outcome. What about when you do cataract and PK together? Well, now you're going to use their corneal keratometry, right? Because you're going to take their cornea off and throw it away. And so using their keratometry does no good at all. So I usually look at what my outcomes are for my last 100 transplants and where I sort of ended up. And so I tell my tech, use a 46K, because that's where I sort of end up, and I usually plan for a little bit myopia. And so, when you do these surgeries, you know that you're not going to get the suture removal becomes very critical afterwards. Now, this patient obviously, coming from a long distance, we don't know what to expect in there. So we're planning to do a triple so that they don't have to have another surgery. My fellow is trying to do a capsulorhexis, but remember, again, with these patients, you don't have a flat anterior chamber or flat anterior capsule, and so they tend to run out. So he did run out, and you can always switch to a can opener. And the reason I like to do these triples is it's so much fun to remove that lens. It's like delivering a baby, and it's and you get this lens that you can show patients. Oh, look, this is what I took out of your eye, and so those are kind of fun to do, which is probably why I do some PK triples. And then I always put a 3-piece lens in these patients because you never know, especially if you've done a can opener, whether you're going to be in the bag or outside the bag. And these are a lot more forgiving if they go into the wrong place. And then you do a transplant just like you normally do. remember, your corneas are going to end up steeper, so which is why I use my last few transplant outcomes. And then your axial length is longer, as we talked about with keratoconus too, but the axial length elongation is usually because the anterior chamber is bigger, and so your lens is further away. So that sort of compensates each other out. But remember, your corneas are going to be steeper, so don't use the other eye, for example. And some final thoughts. We've heard about light adjustable lenses. We've heard about small aperture lenses, and those are good options for these patients because especially in those irregular corneas, the small aperture lenses, and you'll hear another talk on that. You might need to do postoperative refractive surgery, and I've done LASIK on patients or PRK on patients who've had PKs, and you can do them. They're a little bit more challenging. But you might need to do that if you have a refractive surprise or postoperative suture breakage. And then whenever you're in doubt, aim for near. You can only, as long as you can give them useful vision at some distance, they're usually pretty happy about this. Thank you.
Okay, we have microphones in the audience for anybody who has questions. I have one or two, actually, if there's time. First is on corneal relaxing incisions. We developed a nomogram together, David Rootman and Sonia Yu, and David Wong did the mathematics. Femtosecond laser-assisted AK in patients after PK. And we found there actually can be a shift in the surgical equivalent in a fairly significant number of patients. So you do your AK incisions in the graph, the average K value goes from 44 to 46, let's say. So that gets to my question. Do you typically do corneal relaxing incisions at the time of cataract surgery, or do you do it before or after?
That's a great question. I typically do them at the time of cataract surgery, and again, because of my patient population.
Post-PK patients.
The post-PK patients, yes. So I do them at the time of cataract surgery, and I do usually combine them with corneal compression sutures because I find that, at least the ones I'm doing these on, the amount of astigmatism they have does not meet your or does not completely get corrected by your nomogram. And I always over-correct with the sutures. And that way you can always take them out. So I use my sutures as sort of the adjustment. I do and I find that the relaxing incision effect does tend to decline over time. So I do the relaxing incisions following the nomogram. Or sometimes what I'll do is I'll actually just rip the graft host junction in that axis rather than actually doing the AKs within the graft. Gives you a little more oomph if you're doing it closer to the visual axis, a little bit less in the axis, but then I'm not creating yet another weak area on their cornea. And then I use overcorrection with compression sutures to compensate for that. And with that combination of the two, I find that their spherical equivalent pretty much ends up being where I planned it with the IOL.
And then the second question, you mentioned that torics are an option for patients with keratoconus who have a PK for keratoconus, let's say because if the endothelium fails, you're going to be doing endothelial keratoplasty. But I think we've all seen these keratoconic patients, though, who over decades tend to get that thinning at the inferior graft host junction and that anterior protrusion. So I've had the displeasure of doing a fair number of PKs because I had to do a PK on a keratoconic patient because of that sort of ectasia at the inferior graft host junction. And these are folks, many of them with torics in, right, which then becomes problematic. So do you have any suggestions for those in the audience who are thinking about putting a toric in a keratoconic? Is there an age cutoff? Is there things you look for in an exam to look at and say, is this person going to become one of those who's going to get that inferior ectasia and therefore may not be a good candidate for a toric IOL?
Yeah, no, that's a great thought. And now, again, I see those ectasias in the graphs early on after their PKs. So typically when they're in their 60s or 70s and they're getting cataract surgery, if they haven't had that ectasia at that point, they're unlikely to have it. So in those patients, I'm very comfortable doing that. If I have a young patient who, for whatever reason, got a cataract and they need that, then I do not do a toric lens in those patients because I do expect them to change over time.
Right.
But once they're past the age of about 40, I'm a little bit comfortable doing things because I figured they would not get that thinning if they haven't had it at that point. If they have had some, then I'm a little more careful.
Right. Okay. Yes, we have a question here. Yes, sir.
Great talk. I am
Thank
Yamaguchi from Tokyo Dental College, Japan. I have 3 questions. When you perform a triple procedure, what kind of IOL calculator formula do you use? This is the first question. And second
What
one
kind
is
of IOL do I use?
IOL formula,
And we have time for maybe one or two
calculation
questions
formula.
with one more speaker. So.
SRK or high
Oh, formula that I use. Oh, gotcha. I typically use the SRKT formula.
SRK. And second question is, when do you remove sutures? I think removing suture induces myopic six about the 3 diopter. How do you think of?
Yeah, so when I do the PKP triples, my corneas do not end up at 46 when I finish the surgery. So they're much flatter. I estimate that they're going to keep steepening up to 46 after I remove the sutures, which is why I use the 46
I see.
cornea.
That's the third question for me. So you put the K value of 46 diopter.
Right, based on what my
into the-
previous ones ended up.
Thank you.
Thank you.
Thank you very much.